lot of us have worked with Elaine throughout the years, and I'm really thrilled to have her as our guest today. But I wanted to just kind of high level give a few reminders. I can get this thing to work. There we go. Housekeeping. Please put your name and agency in your profile if you can. If you can have your video on, that's great. It just really makes it nice for the speaker to be able to see a face. And also it's great to connect faces with name. If you can have yourself muted, that would also be very helpful with background noise for our speaker. And then if you have any questions, this is really an open format. I know a lot of you have attended several of these, but this is really a great time for those questions and answers and discussion. And really, some policy ideas for the future have come from the Cups of Joe. So thank you so much for that. The purpose of the call is to connect new leadership with statewide leadership. It's to connect all levels of staff with statewide leadership for professional development. So I encourage those of you who are supervisors and managers and you're looking to develop your staff to share this opportunity with your staff. All 15,000 staff of CMHCs are members, and so they are welcome to attend that as a member benefit. It's to learn about statewide resources and to collaborate and work with our statewide partners such as Elaine. And so now I'm going to turn it over to Elaine, but she is going to give introduction. She's going to give some updates, some services that CMHCs can partner on, how best we can collaborate with the HCBS waiver program, and then focus on the PHE ending and the impact on HCBS. I know that that's on top of mind for a lot of us. And then as well as the CAP survey. And then depending on time, you guys know I have some information to share council-wide. So hang tight for me, but I'm going to turn it over to Elaine. Thank you again for being here.
Thanks, Zoe. Thank you for that setup. I appreciate it. And I do love seeing so many familiar faces and names. And yes, unfortunately for you, many of you do know me. But yeah, I'm Elaine Trepanier. I am the outpatient and residential quality improvement team lead at DMHA, which is a big mouthful. So historically at DMHA, I worked on the adult 1959 home and community-based services team, and I was given the opportunity to move into the leadership role for that position. So now overseeing that team, as well as taking on the team that conducts quality improvement reviews for all of the community mental health centers statewide, but also all of the almost 400 addiction service providers statewide too. So I know I'm here today to talk about adult 1959 HCBS, and I have a few updates and thoughts, but I appreciate what Zoe was saying. Like I'm here for you. I'm happy to answer any questions for anything I can't answer. Happy to go back to my leadership and continue the conversation with the rest of DMHA. So yeah, I'm here for you all, and thanks for having me. So I'll start with the more brief item that I wanted to update everyone on, which was the CAP survey. That's just kind of a quick update just to keep everybody looped in. We are at the end of the point where, sorry, let me back up my bus. The CAP survey, Consumer Assessment and Healthcare Provider Survey. It's a CMS approved consumer survey that assesses for actual experience, not perceived experience, if that makes sense. And so just looking to gain insight on ways that we can improve 1959 programming in Indiana. And so we implemented the CAP survey. It's been going for several months now. The actual surveying portion is complete, and the team that is processing the data is doing that now, analyzing all that now. I forget the timeline to expect it, but I think it's within a month or two, which I think is actually pretty good. Our goal was to have 420 respondents, and we well exceeded that and achieved almost 600 respondents, and that was a mix of gentlemen, women, and individuals with various race and ethnicity and diagnoses. So I think we got a good cross-section of who is receiving AMHH and BPHC services to get some good feedback. Also, when we did the rollout webinar back in August of 2022, we got some feedback that CMHCs wanted a provider version, which honestly I didn't expect, but it was great feedback. I really thought you all were surveyed to death. So I was pleased that people were open to it. And so we got permission to expand the survey. Now, the actual CAPS survey designed by CMS isn't designed for the provider portion, but our research team was willing to implement a qualitative approach. So is currently conducting focus groups statewide. And I think almost all of the CMHCs have someone participating. And so again, getting a really good cross-section of the state. But I just really wanted to thank all of you for what a great response rate that we're getting. Obviously, the outcomes are still unknown. As soon as we know what those are, we've previously promised we'll either follow up with like a statewide reporting out, or we may take it on a case-by-case basis, depending on what makes sense with the information. But it is yours too. So we do plan to follow up on that. But really, the response rate was all down to all your collaboration, and we're really, really grateful. So thank you. Any questions or anything about the CAP survey before I move on, or comments for that matter? Cool. So let's talk about Medicaid unwinding, which I'm sure is much more of an interest to all of you. So, of course, the Biden-Harris administration passed the federal spending bill in December of 2022 that parsed out Medicaid eligibility from the federal PHE, and what that means for us in Indiana is come April 1st, we're returning to normal. So the last day of AMHH and BPHC auto enrollments and PHE practices that we were implementing is 3/31 of 23. So just a few weeks away. And I think that we've talked a lot about this along the way, so I don't think there's going to be any surprises. I know we held the discussion a few weeks back, and I am aware that folks are waiting on those slides and that supportive communication to go with that. In full disclosure, that is currently caught up with our communications team, because communications is wanting to make sure that everything that DMHA, DEA, and DDRS are putting out are in lockstep and that the messaging is the same. So as soon as we have it to relay, we will pass it on to all of you, but we're aware that folks are eager to have that information in hand. I'm doing my best to nag the communications team, I promise. So then the only other federal PHE update is, of course, the federal PHE itself is ending May 11th, 2023. And with that, the 1135 SPA that we had in place too, that allowed for home and community-based services to be provided in alternate settings. So that expires May 11th of this year too. So questions, comments? I know that this is the one that has the most impact on the day-to-day. So I'm sure there's a lot of moving parts going on out there that maybe we're not familiar with.
Yeah, I know our quality committee, I'm trying to see if Rona is on, or chair, had several questions. I see Charlotte and a couple others around some of the clinical documentation requirements that went away during the PHE, if those are going to be started back, and also the question around the quality measures and those outcomes, and if that will be coming back as well. So I didn't know if you had answers around those. Charlotte or quality committee members, did I highlight that discussion well enough?
You captured them well, Zoe. Thank you.
Oh, there you are.
Good morning, Rona. So there was a let's start with the clinical documentation question. What can someone expand on that? What questions are there for that?
So the question that had been asked by several of our providers, Elaine, was we recall that at the beginning of the pandemic, there had been some exceptions that had been provided around treatment plan signatures and things of that nature. And while those are not specific to 1915I, BPHC, and AMHH and the other, that has been a question, and we've not seen anything come out about that. And I believe that there were some others that were a part of those exceptions at the time, and we just want to understand what that is going forward.
Okay, that's a great question. So especially with using telehealth services, we had some flexibility. Obviously, if you're providing telehealth, you can't capture a signature. And so what we had been looking for in the 1959 world, and that I'm transferring for consistency over to the clinical team as well, is if any service is provided telehealth, that it just be documented in the progress note that verbal agreement or authorization was obtained, especially around treatment plan or IICP development, or treatment plan or IICP review. And if that narrative is in the progress note and we can see that and it matches up with any other, sometimes there's correlating documentation, sometimes there's not, but if we can see a narrative that a verbal agreement was obtained, then we're counting that as a verbal signature, basically. And so I can't really envision any other times outside of telehealth that would be true for, but of course, for Indiana, majority of the telehealth practices are now part of IAC and are continuing. And so we will continue to review charts based on that, looking for that narrative of that verbal agreement. Does that make sense?
So I'm hearing you say that for verbal consent is acceptable for telehealth service.
Yeah, it just needs to be narrated in the progress note.
Okay. And in terms of QA auditing going forward, then for non-telehealth services, can you speak to the expectation going forward past the PHE?
Sure. Yeah. So if a clinician is with an individual, either at home, in the office, or in the community, and there is an IICP development or all of the documentation that goes with 1959 application or reapplication, if you're in person, then we would prefer to see a signature. In 1959, in the provider module, there is an allowance. Individuals may be too symptomatic or having a rationale for not providing signature on that day. Maybe something is going on with them personally, and a signature can't be obtained. That is fine. That can just be documented in the progress note why the individual was choosing not to sign. But generally, by and large, individuals, they do want to sign their documents, right? That's their involvement. And so when in person, that's what we'd expect to see from the clinical team. If in person, then IAC, Indiana Administrative Code, is pretty clear on getting signatures to demonstrate participation in treatment plan and treatment plan review. So if in person, those signatures would ideally be there. If individuals are symptomatic and it's causing more stress, then is beneficial to get the signature. Again, in the document, in the progress note, clinicians can document why an individual refused to sign or was unable to sign. And there's an allowance for that in IAC as well.
Thanks so much, Elaine.
Yeah. And so then does that address the documentation piece before we move on to, was there another question?
It was just around the payment bonus outcomes that were in place prior to that, then with the PHE and those changes went away. And then the question is, will that come back, or what will that look like for delivering on those outcomes?
So Elaine,
So-
I think that's associated to the Dharma funds or funds associated to Dharma. So I think to this point, the performance dollars have not been, we've not been held responsible for performance, and those dollars have been allocated. And what will
Okay.
that look like going forward with the PHE ending?
That is a question that I'm grateful is outside of my scope, but I'm happy to take that to my leadership and relay that that's an outstanding question for this group, and that folks are curious to get an answer on.
Yeah,
Go ahead.
when I mentioned it before, I was told it was more of a bandwidth issue, but that's been a while, so it would be worth checking in.
Okay, when I respond, who is that response going to?
You could send it to me, and then I could
Okay.
provide that education to these wonderful folks on the Zoom.
Okay. Okay, thanks for letting me know that that was something still outstanding. Okay. Cool. What else? What else is going on?
Or what other questions do you guys have in regard to the PHE? I know there's a call today with FSSA talking about the Medicaid unwinding and the stakeholder resources that we shared in our update. And we'll also share it on this slide, but if there's anything else in particular to DMHA, Elaine would be a great resource to connect with. And I think, Elaine, one of the things that, as we're waiting for people to think of questions, one of the things when you and I connected a while back that we talked about was getting people more connected to the HCBS waiver and having people use that more. Do you want to kind of talk about that a little bit and how people can get connected to that?
I'm trying to recall our conversation and what the context was.
It was more around just utilization and getting people comfortable with using it, and how to get people, clients connected to it. So that could be some good education for some of our, newer staff.
Sure. So well, one, if anyone ever wants to have a conversation one-on-one or a smaller group about the nuances of AMHH or BPHC, we are always happy to have those conversations if a one-to-one training makes sense. BPHC is our most used program. It currently has over 3,000 folks on it statewide, but we know probably a fair percentage of those now are individuals who have been maintained because of the federal PHE. So we haven't had a good view of what our actual concrete utilization looks like in 3 years. So to be continued on that, but BPHC is behavioral and primary healthcare coordination. So it's a single service. It is care coordination that is intended for individuals who have complex mental health, physical health, and possibly substance use disorder needs as well. And so it's that extra bit of support to help them remain at home and in the community. So we do see a fair bit of BPHC being utilized. The way we have 1915I structured in Indiana is only the community mental health centers are certified to provide 1915I programming. So CMHCs are the only ones allowed to be the providers. And so these would be your clients that are ANSYS 3 or higher, and like I said, who would present with that complexity of mental health, physical health, and or substance use disorder needs. So that's kind of a target individual to keep in mind. Happy to discuss that further. The program that we really see very, very underutilized is AMHH, adult mental health habilitation. And currently we have, in full disclosure, we have less than 20 folks on that program statewide. And I know that there's been intermittent utilization. I know when the program first rolled out that there were more folks on the program, and through various reasons, things have dropped off. I know it's not a popular program from the CMHC perspective, because of sort of the philosophical piece with, it's habilitation rather than rehabilitation. So I understand that it's a difficult place to get to think that a consumer perhaps is in a state of maintenance rather than still having the possibility of growth or gain. And so that's one significant area that we know is an impediment to AMHH utilization. But I mean, all the folks on this screen that are familiar faces to me, we've had long conversations about AMHH. Kelly, not to out you, but we've had lots of conversations about it. Interestingly, we have a lot of consumers or individuals in the community that contact us that want AMHH. And so we get asked about how to access that. And obviously our job is to just be a linkage to this community mental health center and allow your staff to do the good work of the assessing and evaluation of what makes sense for the individuals. So we don't influence that process at all, just provide the linkage. So I mean, Zoe, I'd love to answer your question more about like how do we improve utilization, but I honestly, like I said, with BPHC, we're at the tail end of the public health emergency, so I don't know what true utilization looks like right now. And then with AMHH, we know it's a flawed system. I think, Zoe, we'd also been talking about sort of that cross-section of division of aging with use of BP or 1959 programming, and internally at DMHA, we have a new, it was a new role. Kate Heeger, I'm sure you all know her, are familiar with her, but she's working on, focused on the aging population and mental health. And so I've been encouraging her to work with the AAAs and relay to them that this resource of 1959 is available in the community. And I think that there is some discussions booked for later on this year to just make sure that AAAs are aware of this resource. But I guess that, in reciprocity, that goes the other way too. I know CMHCs probably have great relationships with their local AAAs, and just reinforcing that 1959 is available for those individuals, and they can have both 1915C waiver services and 1959 programming too. And so so that is an option. So I'm happy to talk about that more, but I guess the main update right now is that DMHA is aware that that gap needs filling and is in the works of trying to provide that education to the AAA side as well.
That's great. And Kate is on my list for a future Cup of Joe.
Oh, good.
Guest, but we are pretty booked out. It's a pretty hot, as you can tell with how many people hop on. It's so I'm glad we were able to get you into this space to talk. Any other questions before, keeping my eye on the time, before we move into council updates?
Yeah, hey, this is Kristen. Just one question for Elaine. You talked about the ending of the alternative settings. I was wondering if you could review those. It's been so long since we've been under the changes, that just to solidify that we all know what those settings were.
Sure. There actually wasn't a specific, like for 1959, there wasn't a specific setting type. In full disclosure, this affects less than a dozen of our BPHC consumers statewide. And what occurred for us was that there were some individuals who were found to be in non-compliant settings. And we had to use the member transition plan to allow them to either choose to remain in the non-compliant setting and forgo programming, or move to a compliant setting to keep programming. And with the federal PHE, they exhausted that member transition plan process, and so continue to remain living in an ineligible setting. And so for those individuals now, they're going to be allowed to complete the package service that they're in. And if it goes beyond May, come 4/1, finish the package that they're on. But if their package goes beyond May 11th, they won't be able to receive home-based services because of that 1135 waiver. So they'll have to go fully to community or office-based services. And again, I'm working on that communication to push out so that everyone has it formally, but there's a lot congested with our communications team at the moment, but it's drafted, it's just waiting for approval. So we'll get that out so folks can have it in hand. So not a lot of folks affected by this, and the ones who are pretty well aware that they've been on a member transition plan for up to years now. So they expect this, so it won't be a surprise.
Great question.
Thank you for having me. And anyone can email me with any other questions too. I'm happy to answer them, and I will follow up about the performance funds as well.
Yeah, I just wanted to publicly thank you for being so responsive and being someone at DMHA who is such an advocate for our services. So one of the other things I did want to share is someone did share the concern regarding, if you did see it, folks, about the DDRS rates going up and changing, and why is mental health not a part of that from an MRO standpoint. So I did forward that on to Elaine, Gina, and Ari to see if we can get anywhere on that and part of that process. What the timeline is on all of it is CCBHC and how that impact will be on our system. And so it's kind of, there's a gap there, but Elaine has been someone who has helped with that advocacy and that follow-up. So I just want to publicly thank you for being so responsive and for your advocacy. So
yeah, my pleasure. And I do want you to know I've already passed it on to my leadership and OMPP is already kind of working in the background about where to best take your advocacy to. So just to know that's in the works.
All right, perfect. Thank you. That's awesome. So, well, we're going to just jump. You can hang on, Elaine, to hear these updates as well, but we're going to jump real quick.
Thank you, everyone.
Yes, thank you. 2 updates. A lot of these were in my update that I send out. I call it the Zoe in her head data dump for all of you. If you are not on that email list, please reach out to Denise. Upcoming events, we have several things happening. One, today, FSSA, I put this at the top, is talking about the Medicaid unwinding and the stakeholder resources. We will be working with Covering Kids and Family on a toolkit that we will be getting to all of you here shortly. And we are also, as a part 2 to this Medicaid unwinding discussion, we'll have all of our managed care organization on in April, the first part of April, to talk about specifically what they are doing around their efforts for keeping folks enrolled, because they all kind of are doing it differently. So more to come on that. I did also want to call to everyone's attention the April 4th Cup of Joe will be IPLA. They have been doing a ton of work in improving the licensure process. They have hired new staff, and one in particular, well, actually 2, I've been extremely impressed with. And so they are coming to share about those updates and improvements that they are working on. And then, of course, May 11th and 12th is our spring conference. We are working on topics. We will be celebrating our Legislator of the Year, and we will also be celebrating Barb Scott at Aspire and so much more. So please block that time on your calendar. And then the other updates, because this just jumped ahead on me, If you have not gotten onto our website for the email discussions and the listservs and getting connected, Quality Committee did a great job using that committee time to talk about how to use the website and that listserv. If you need help and how to do that, please connect with Denise so that she can help you. But we are really wanting this to be a resource-rich resource for all of you. And so I wanted to let you know that section is up there. The newsletter will be out this month, and then everything else here listed has been shared in my update. I did want to call two things out because I'm getting regular questions on that. The grant funds are being administered. State Budget Office has been slow. We did receive a payment that we submitted back in November, finally yesterday. So we will be getting some of that payment out to folks, as well as the CSU grants should be made the end of March. And the DMHA recruitment and retention innovation funding is posted. I've had several of you ask me if the council is going to apply for that. We decided, the board, last week that this is a local effort and initiative. And so we will not be, but we will be here to support you. So if you need letters of support, or if you need any help with connections, please reach out, because I want to ensure that that funding gets into our members' hands. And then March 16th is the planning grant for CCBHC. I will make sure to share that if we did get that awarded. And then two, federally, SAMHSA is releasing more CCBHC grant funding. I keep hearing like end of March, but of course I put April because we know how things work. So I will share that as soon as I hear that, but I did want people to be aware of that and have eyes and ears open for that. Membership survey, a quick thank you for everyone who completed. And then if you know of any potential new members, please reach out to Leanne, who's on, so that she can follow up with them. I also have to put a reminder for our PAC. And so if you are interested in contributing or learning more about that, please let me know. And then if you have any feedback, speakers for either these sessions or the conference, either reach out to Denise or myself. And so we do have a winner for our Starbucks gift card, and that is Katie Huber with Centerstone. So we will get that gift card to you. And then last but not least, you'll see my last thing here. Tomorrow I'm meeting with the Senate budget staff, and we are talking about fully funding SB1. You've seen in my updates, you've seen in some emails, call to action. If you have not yet reached out to your local legislators about fully funding SB1, please do so, because we are in the second half of this legislative session, and we need to hear, they need to hear from all of you. So fully fund SB1. I will be sharing more specifics about that language once I meet with them tomorrow. I could also send out a template for folks of those talking points, but right now our message is simple. It's fully fund SB1, that's for certified community behavioral health clinics, and 988. So you have those resources, but if you need help with any of them, please do not hesitate to reach out. So I know I'm 5 minutes over, but raise your cups. It's March Madness, yay! And cheers to all of you for the great work that you do. If there's anything that you need, please do not hesitate to reach out. I appreciate all of you. Have a fantastic day.